What are some of the qualities of a good assessment of learning? Yes. Yes, and I'm going to keep reminding people that you definitely need to turn on your microphone. Thank you.
So probably the main thing that came out at our table was you need to know what level of communication you're trying to assess. And as John pointed out, if you're good at clinician-patient communication, that doesn't necessarily scale up to the team or to groups or communities, and that we need to be focused on what kind of assessment we're actually doing. And one example we had of an assessment tool that does focus on a specific kind of interpersonal communication is Lorelei Lingard's tool for assessing communication in the operating room.
Excellent. So this is a lot more complicated. It's not just communication, it's communicating with who, between who.
And for what purpose?
Right. Anything else? The assessment of learning? Yes.
Our table went a little bit in a different direction in the fact that frequently in the communication, we know how to observe clinical and we can check off those boxes, but whoever it is that is doing the assessment around communication and professionalism and how that occurs frequently does not have standardized metrics. So it's all kind of in the eye of the beholder, and the beholder may not be either of the same culture or wherever, whether it has to do with a student or a patient. So we came up with just brainstorming different elements that there are probably assessment metrics out there that need to be brought in. One having to do with mutual respect, empathy, compassion. It's a two-way street. It's not just one way. Evidence-informed, shared decision-making, cultural humility, and looking at the professionalism and how it is that that would be both defined across different disciplines, which we spent a lot of time on the last meeting about, but also what that means to people just in terms of professional communication with patients, students, and other groups. So we looked at elements, and that there probably are instruments that have these elements that could be brought into our assessment instruments rather than just having that be the subjective part of an assessment for students.
Anybody else? Yes, Meg?
So we talked about clinical simulation around the safe environment modality. And we talked about its value in assessing communication among the various parties. We had a little bit of a conversation because our facilitator was confused about among and between. So we had a little bit of a...
That was you.
I was going to say. She's talking about herself.
Thanks, Sarita. Thanks. There's another lawyer at my table. I think that's a problem. And then we had this really interesting conversation about simulation being sort of an outside of the real world, and the response to that sort of was it's one tool among many, and that maybe there's a timing to it, so that simulation sort of precedes see one, do one, and teach one, and makes that kind of process a little bit less anxiety provoking. And then one of our students raised a really interesting point about simulation being really dependent, like that there's a danger that simulation will or can embed unintended biases by sort of what shows up and what doesn't show up in the simulation. And that even if what we do is represent authenticity, best, let's say, we manage somehow to know that we're representing an authentic environment is not actually an aspirational environment. And so in a learning context, if it's accurate to exclude social workers because social workers probably wouldn't be there, aren't we kind of training our students to continue to exclude social workers in the practice environment? So we had a really interesting conversation about simulation.
Certainly sounds like it. And simulation as an assessment of learning. Yes.
We actually had a discussion of simulation as well, and discussed one of the issues with simulated learning is that there's a kind of often a Hawthorne effect that happens. that people know they're being, sorry, oops. People are just talking about the problem with the Hawthorne effect with simulation, that once people are in there sort of doing their simulated activities, they realize they're being watched, their performance is being watched. So often they play very sort of nice. And I've seen it in interprofessional education sort of scenarios that often you get a very polished version of a kind of teamwork performance, which then doesn't happen in real life. So just to be sort of mindful about the limitations of simulation.
Yes. Oh, yes.
In terms of thinking about the assessment of communication, it seems like it should be measured in the doctor's ability to bring about a change in patients, whether it's in their understanding or their behaviors that may be causing the problems, or even in their outcomes. It really comes down to, if you have the great plan and they don't follow it, it doesn't matter that it was a great plan. The ability to communicate it can actually be measured in those three things.
Certainly behavior is more, demonstrated behavior after a communication is not necessarily a measure of communication. I mean, that's where it gets really complicated, right? Yes.
I think regarding what makes a good tool, at this table we didn't discuss that directly, but indirectly, I think what was emerging from the table was that the tool, one should be able to standardize the measure or the tool. Because, for example, mention was made that we can do direct observations. The question was, how do you standardize that? So I think standardization as an idea.
As a goal?
Yes, as a goal is important.
I'd like to hear, how do we engage patients and users of healthcare system to, in the process of assessment of learning? Did we talk about that? Patients' assessment of communication.
Actually, we had the second question, so we were talking about for learning, but we
Okay,
were very
we can
focused
segue
on
there.
that. If we could segue into that, I'd be happy to share. We had a great conversation about how we could better get feedback from the patients in the process, and that led us into a couple of really interesting dilemmas. Are you getting feedback about an individual who's delivering services in the context of a team, or the team as they're functioning in their interactions? And we also talked a lot about the differences between verbal communication as being important to measure, but nonverbal communication as well, and how people interact is very different than what they may be saying to somebody, and giving them feedback about both dimensions really matters. We really struggled with the idea of how you would ideally measure that. We talked about the concepts of getting feedback that's timely, but also in a way that the person who's providing the feedback feels safe to give clear and directive feedback about the interactions. And the dilemma, if that feedback is about a whole team, well, how do you craft that if one member of the team is functioning very differently than other members of the team, and how that might look? We came up with some potential ideas in terms of obviously getting some type of report about the types of interactions that an individual experienced. And the dilemma then was, how do we communicate that feedback to the individual or to the teams in a way that they can process that information and hopefully engage in some behavioral change as a result of that.
Excellent. Eric?
We had a wonderful conversation with Connie about her recent experience where she's admitted to an academic medical center and had a team come in, and how she was able to observe the team dynamic of what happened around her bed with the resident and the other interns and stuff. And that, to me, is a missed opportunity. She wonderfully described what was happening, the interpersonal dynamics between the interns and the resident, how the resident was treating her. And I love your quote, Connie, where you said, the resident cared about me medically, but not emotionally. And she was able to make that distinction. I thought that was incredibly powerful.
Yes.
We did not discuss this in this group, but I just want to, oh, sorry.
Excuse me.
If Connie wants to, go ahead.
I'm just wondering, because I certainly don't know, but in medical schools today, is the relationship between doctors and patients discussed at all? I don't mean that sarcastically, because most of my experience has been wonderful. But I do wonder, is it? Because I think it should be.
Yeah.
And it should be called bedside manners.
Thank you. Carol, I've cut her off, and I'll come back to you. What was that? It's an elective?
She said it's an elective.
So just to respond to Connie first, thank you, Connie, for bringing that up. Definitely, the relationship between patients and nurses are discussed a lot in schools of nursing. So there is a lot of focus on that. But one thing that we did not discuss in this group, and I just want to alert us to it, in observing teams and trying to make a decision about communication styles and communication effectiveness, we have to take into consideration gender because there are a lot of work about how women communicate as compared to men. We have to take into consideration the power structure, and we have to take into consideration also diversity and inclusiveness. So we do judge people about their being verbal or their body language, and we have to put that in a context to gender and diversity.
One of the things too, and then I'll pass it to Carol. One of the things that occurred to me is that I'm not sure how I would answer this. I'm just going to throw it out. If the team has a high communication skill, does that mean that everybody on that team needs to have the same? Or do we play different roles on that team? I mean, really, I think we're probably more interested in making sure that the outcome, that the person and the family, the caregiver, gets what they need, whether it comes from 2 members of that team or all of them or just one, that it's really about the roles that we play on the team, and certainly the communication among the team members.
Connie raises a really important question and stimulated me to think about this in a way I don't think I ever had before, because we have, for 30 years at least that I know of in medicine, included communication skills a lot in the curriculum, but we still have this complaint, and other professions do. And the thing I think we have to remember is the formation process, education and training, is a very different context. In some ways, it's not real life. And we can't just look at what's happening in that process. We have to say, what is it about the practice context that reinforces those communication skills or, in fact, works against them? And I would say today, in many of the practice contexts, there's a lot that works against good communication skills, whether it's the team or the individual professional.
So do we just accept that? I mean, like, this is, again, how can we as health professional educators change the practice? Yes. Your microphone? That's okay.
To take advantage of the literature that's out there with regard to the relationship between what we've learned in aviation versus what happens. The sine qua non was to remove the fear to communicate in the first place because of the power structure. And I think for a number one goal within any dynamic of communication, that we've got to work on how we can do that, where no matter who it is at the table is willing and knows that they can, without fear of intimidation or being fired, as in
fail.
Speak up. So you got to say something before you can communicate.
Excellent point.
Thank you for that comment, and I just wanted to illustrate, I heard last week an example of a problem with a attending physician that was very aggressive about their team when she was not getting what she wanted. And the question was, how do you provide feedback to someone like that? And the actual incident, the program director said, "You are not safe." Rather than "you're not nice, you're not a team member," they use that as the safety issue. If you are intimidating people, you are not a safe practitioner. And I thought that was very powerful.
Ever?
Bev Malone, I think fear is a pretty good thing. I think it's a warning system that you are in a particular situation. So I would say that we have to challenge people acknowledging that there is some fear about a differential in terms of power. We need to be realistic about it. If I'm talking to someone that I believe has more power than me, I need to know that. I don't need to be so numb or whatever that I don't understand the system that I'm working in and that I am in a interesting, delicate situation as I challenge it. And I find, as someone who's been challenging for a period of time in life, that it takes practice, that you do it again and again, and sometimes you have to work yourself up to do it. But acknowledging the system that you're in and the imbalances of power that could create a situation of fear, I don't think anybody can really take that out of the system. That's reality. And I think that we need to help folks understand the risk they're taking, but that it's worth it because the patient care, the safety issues are paramount. And so when you do it, it's not without fear, but it is with a conviction that it needs to be done.
I'm going to do one, and then two, and then the final question here. Thank you.
Yes, I just wanted to follow up on that comment. I think there's one thing about the hidden curriculum in all of this, but I think there's also, we all know that the culture, the institutional culture, whether it's in the hospital or in the academic setting, is going to either reinforce this kind of safety or not. So it needs to be, the assessment can feed back into the process of being aware what kind of culture is there. Is it, because you could put that in the curriculum, you can have training around it, but if it's not practiced out there, people are going to, these power structures are going to be reinforced.
Mm-hmm.
Just quickly following up on Bev's point, I want to, when I was here last October, I guess it was, mention the work of Parker Palmer around this and Diana Chapman Walsh and some other folks who talk about this. I think what we're getting at here is the tension between system reform and individual, sort of ethical practice.
Mm-hmm.
And this is a tension or a polarity that will likely remain for a long time. But I really want to underscore Bev's point about the importance of informing people that it is dangerous, but that it's really important to do it as part of as part of ethics, and as Susan said, as part of professional safety, sort of in the organization and the education pieces.
Absolutely. And finally?
Yes, John Finnegan, and I couldn't agree more with this. And here's an example of how different dynamics of communication and power at different levels are going to influence interpersonal communication. It wasn't that long ago, 2005, 2006, when the Joint Commission took a look at where the errors come from in patient handoffs and things like that. And I think it was about, somewhere in the 2/3 range plus of the errors that occurred were because of errors in communication. Now, that didn't necessarily mean somebody transmitted the wrong information. It means because also some didn't say anything. There was a spiral of silence because there was a fear of retribution. So this gets to the point that communication in an organizational setting is strongly influenced by that culture. Mm-hmm. And if you don't pay attention to that, the interpersonal skills that people may have may not be exercised in the right way. And you can teach them that till the cows come home. But it's really going to be that larger organizational framework that's got to change, that culture that's got to be a safe culture, as they said.
So one of the things that all of this raises is that we're not just talking about patients and families feeling safe speaking up, but the professions involved, right? Because, safety might seem like a really strong word to say there, but there is a sense of power and hierarchy and so forth. And so we need to be cognizant of that, and I'm sure that's also going on around your tables here as we represent different professions, that we really need to make sure that we're inviting. And yet you're not supposed to be taking care of making sure that everybody speaks up. But when someone does, really paying attention to that, sitting with it instead of moving directly onto something else. I think that's one of the things that happens. So now I'm going to move us on to the next two questions. And I'm going to ask tables 1, 2, 3, and 4 to look at question 3. 4, 5, 6, and 7 to look at question 4. The rest of you are going to decide which of those seem more interesting. And now we're actually going to look at assessment as a catalyst for change. This is the other part of what we thought about and talked about this morning. The first question, 3, is in what way might the assessment of learners be a catalyst for change in education? And how might assessment of learners be a catalyst for change in the system? So those are 2 different lenses. Again, there's going to be overlap, but we really want to think about how can assessment of learners change education, the structure, the program, the curricula, the pedagogy, all of that, and how might it change the healthcare system? And I'm going to give you 10 minutes to talk about those questions.